In this video, we'll present a complex case of an endovascular stent revascularization of a subacute and chronic internal carotid artery occlusion using a intracranial and extracranial stenting reconstruction. The patient is a 47-year-old female who presented to the emergency room complaining of transient right facial numbness, arm paresthesias, and slurred speech. At the time she was seen in the emergency room, her NIH score was 0. She had only past medical history of migraines. CT was normal. MRI demonstrated a small left frontal acute stroke. CT angiography demonstrated complete occlusion of the left internal carotid artery, and perfusion at the time showed slightly increased time to peak with preserved volume on the left ICA territory. At that point, the patient was admitted and was given heparin drip for about 2 or 3 days. During the time she presented other symptoms. A second CT perfusion with acetazolamide challenge demonstrate poor left hemisphere cerebral reserve. Here you can observe in the CTA complete occlusion of the left internal carotid artery and 4 CTA of the cerebral vascularity with quote-unquote normal vasculature. Initial CT perfusion demonstrated increased time to peak slightly on the left hemisphere with preserved volume. We repeated the CT perfusion with acetazolamide challenge, and the pre compared to the post, we see significant increased time to peak changes on the left hemisphere with still preserved volume. We therefore elected to revascularize with stenting. You can observe here in this angiogram complete left internal carotid artery occlusion. We and then an intracranial run demonstrate some filling of the internal carotid artery through collaterals from the external carotid artery. However, those collaterals were not enough for this patient. So we advanced a balloon guide catheter into the internal carotid artery, doing a cervical angiogram for roadmap, and under floor rest you can see the balloon of the balloon guide catheter inflated. We explore the cervical internal carotid artery with a micro wire and a micro catheter, trying to find the lumen of the artery. While passing the micro wire, we felt some resistance, indicating that we have reached the site of the possible dissection that led to occlusion of this artery. Now we're using intravascular ultrasound to observe the free flap of the dissection and potential intraluminal thrombus that we're not able to see in angiography. Now we're crossing what we think the lesion is. The dissection is right there at the cavernous segment. It's difficult to estimate the length of the dissection. We're now confirming that we have reached intracranial vasculature and it's all patent. We have the microcatheter at the left middle cerebral artery, so obtaining adequate distal access. The next step is to aspirate all the possible intraluminal thrombus. Here where we're passing the reperfusion catheter, aspiration catheter, we felt some resistance. Therefore we somehow limited the segment of the dissection. In order to reduce the dissection, the first stent is a wingspan stent, and this is delivery and apply covering the distal portion of the dissection. Right now we are delivering the wingspan stent. We're doing it slowly, so we've achieved a perfect position Right there you observe how the distal portion of the stent just opened, and here we're about to open the proximal part just right now, leaving the microwire distally. We felt that a second device was required, so we went ahead and deployed a second device in a telescoping manner. A portion of this distal segment of the second stent is deploying within the first stent. Right now we're deploying the distal segment of the second device. That it's been telescoped with the first device, and then again slowly deploying the rest of the stent. And right now we are finally deploying the proximal portion just open. Now the caliber of the additive has increased. We are at the distal portion of the cervical segment, therefore we need a longer stent. We're using a taper carotid artery stent, a 6 by 8 by 36 centimeter stent, a flexible open cell stent, so it takes the configuration of the tortuosity of the carotid artery. And observe how the balloon is still inflated, so we are doing all this under floor rest to prevent intracranial emboli. A second stent is required in order for us to reconstitute the entire length of the carotid artery down to the bifurcation. We had to deflate the balloon in order to deploy the entire length of the stent, and you can see how nicely this internal carotid artery has been reconstructed, obtaining adequate revascularization of the left hemisphere. Thank you.